So, with that out of the way, allow me to briefly introduce today's speaker. And Dr. Allen, we'll give you a chance to go ahead and get your slides set up as well. But Dr. Jessica Cornett Allen has been working for the Indian Health Service at Northern Navajo Medical Center in Shiprock, New Mexico since 2016, after completing her family medicine residency at St. Mary's in Grand Junction, Colorado. She had focused training in HIV and hepatitis C medicine, earning an American Academy of HIV Medicine Specialist certificate. She teaches for the UNM Shiprock Family Medicine Rural Training Track, and in her free time, she enjoys hiking and camping with her husband and two daughters. With that said, Dr. Allen, thank you very much for joining us today, and the floor is yours.
Hello, and thank you very much for that introduction. I'm excited to talk to you about hepatitis C treatment because I really think this is something that can be done in the primary care setting with the new modern medicines that we have these days. I suppose they're not new now because they've been around for 10 years. So I hope our new generations of residents will be coming out of residency more confident about treating hepatitis C. I have no disclosures. I will say I tend to speak quickly when I'm really excited about something. So if you need me to slow down, let me know. I am very excited about hepatitis C treatment. It is one of my favorite parts of my job as a family medicine doctor here in Shiprock, New Mexico. What we're going to go over today is just briefly how to screen for hepatitis C. The recommendations have changed over the years. This is maybe what you're most familiar about already, though. The pre-treatment and post-treatment evaluation and how to treat hepatitis C. And I really think this is possible in the primary care setting. Learning points, if you, if you don't listen to the rest of the presentation, these are the things that I hope you learn today. That the hepatitis C medications that we have these days are safe, easy, they have minimal side effects, and they're very, very, very effective. There are very few contraindications to treatment, and there are medication interactions. However, even with basic and over-the-counter medicines, you've noted I have listed PPIs and statins as some of the main offenders. In terms of testing people for hepatitis C, I hope people know that a positive hepatitis C antibody is not mean a person has active hepatitis C infection. And then the most important thing is that treating hepatitis C early saves lives and money. So who do we screen? Well, I suppose all of these things depend upon who you ask, but according to the USPSTF, you screen all adults aged 18 through 79 years at least once. There's additional recommendations from many different organizations for screening based on risk factors. So people who use IV drugs, have unprofessional tattoos or piercings, have been in jail for more than 3 days. What an interesting one. I guess that's what they looked at on the survey. People living with HIV and men who have sex with men. In our population here in Shiprock, the unprofessional tattoos has been one of the most common risk factors that we found in our patient population. It's interesting that men who have sex with men is on this list because we don't think of hepatitis C as a sexually transmitted infection. And it's not entirely clear how often it is transmitted sexually. I would go with like on the side of rarely sexually translated. So, but it's unknown if that it is sexually translated in that patient population or if there are other co-current risk factors that are involved. Here are additional risk factors that are listed. Interestingly, intranasal drugs, I'm not entirely sure exactly the biology of how that happens. Hemodialysis patients, modern, not so much, but patients that have been on hemodialysis for a really long time, before organs and blood things were tested for that kind of stuff. So like before 1987. Children born to mothers infected with hepatitis C. Hepatitis C vertical transmission is a pretty low rate, only about 5%, but it is possible. And then less common risks include sexual contact and then sharing personal items. I think the most common question I get from my patients that I'm seeing for the first time are, how can I prevent giving this to other people? And they have been avoiding all this time um, hugging their family members or sharing drinks with them. And so, one of the most important pieces of counseling I do with my patients on our first meetings is letting them know that it is safe for them to hug their grandchildren. It is safe for them to hug their children. It is safe to share drinks as long as there's not blood being shared in those drinks. I also go over with patients the natural history of hepatitis C. It doesn't cause problems overnight, and most people don't even feel it or know that they have it. And this is very similar to how I talk to patients about it. So you start with a normal liver and it's happy and it gets lots of good blood flow, but then the hepatitis C gets in there and it just spends years and years beating up on the liver. Not everybody's liver is going to get so beat up that it develops a chronic inflammation, and not everybody's liver is going to get so beat up that that chronic inflammation causes scarring or cirrhosis. And then a very small percentage of those people can go on to develop hepatocellular carcinoma or end-stage liver disease. And this isn't a quick process. It happens over long periods of time. I oftentimes will tell my patients, though, that the things that speed this process up are other things in our lives. So, for instance, if we have diabetes and our diabetes is poorly controlled or our sugars are just too high, then this process might be sped up. Similarly, if we're using alcohol or other drugs that can hurt the liver, then you have multiple things beating up on your liver, and that can accelerate this process as well. All right, so this goes to one of the learning points, which is what does a positive hepatitis C antibody mean? Looking at some regional data over that was collected 8 years ago, we looked at a group of 256 patients who were positive for the hepatitis C antibody. Back then, we didn't necessarily reflex to viral load, but I think most labs now and most places will reflex your testing to viral load, because what comes back is that if they have a negative viral load, that means they do not have an active hepatitis C infection. And it showed in our data that only 50% of the people who had their viral load checked actually had a hepatitis C infection, which means that 50% of the positive antibodies were false positives. So patients can get really scared if you call them with preliminary information and say your hepatitis C test was positive, and they get really worried and they're like, oh my gosh, how does this happen? So I usually wait to see until that viral load comes back, because I know that my antibody is a 50% false positive rate. And that also depends, the false positivity rate does depend on the prevalence in your patient population. And the 50% false positivity rate is pretty consistent with a low prevalence patient population in other populations as well. This is what it looks like at our facility with the hepatitis C lab. This quantitation stands for like a hepatitis C viral load, and less than 12 means undetectable, means it's not there. And this was what it looks like when in our lab, when you have a person with a positive hepatitis C viral load. That hep C quantitation is the viral load. Our testing here also, from a positive antibody, reflexes to a genotype and a viral load as well. And if your lab or the test you're ordering is not doing that, I do recommend it, because it is just such a project. If you have to get people in for 3 separate lab draws, one for the antibody, one for the viral load, and one for the genotype. But I think most places should be doing that by now. All right, why do we want to treat hepatitis C? Treating hepatitis C saves lives and money. There's a I can read the slide just as well as you can, but basically lots of things get better. Though the thing that on this slide that I think is the most interesting actually is there's a decreased risk of or remission of diabetes if a person has diabetes. The idea is that hepatitis C is a chronic inflammatory state, and inflammation raises our blood sugars. So if you get rid of the hepatitis C and the chronic inflammation, the blood sugars can come back down a little bit, similar to the reason that we do like dental screenings for our patients with diabetes. But um, there's a 90% reduction in liver-related mortality. There's even resolution of cirrhosis, like the liver regenerates itself. What a cool organ. Mhm. All right. This is a graph that just shows that, hey, hepatitis C treatment really does make a difference. So the red bars are the people who were not cured, and the blue bars are the people that were cured. And so you see the blue bars are much shorter, meaning there were very few, there were a lot fewer people who died, developed hepatocellular carcinoma, liver failure, or some sort of liver-related mortality or transplant. More graphs showing the same thing. Um, there are also other things that if you want to add these to your differential diagnosis and things that you think about that you can expect when you cure somebody's hepatitis C. So I mentioned that people's insulin resistance and diabetes can improve. The porphyria is associated with hepatitis C, and that can improve as well. People can get a hepatitis C kidney injury, which is the glomerulonephritis listed there. That can improve as well. And the cryoglobulinemia. I do not test everybody with hepatitis C for a cryoglobulinemia. Just kind of depends upon the case, and oftentimes that's associated with the glomerulonephritis. And so I use either rashes or glomerulonephritis as my trigger for screening for cryoglobulinemia. Treatment is prevention. So another reason not mentioned, besides the fact that the treatment saves lives, it also prevents other infections. So for every one person who uses IV drugs, treating that one person prevents 2 new infections. So the U equal U stands for undetectable equals untransmittable. That is a widely known campaign in the HIV treatment world, where, however, it's also applicable here for hepatitis C treatment. So treating one person that uses IV drugs prevents 2 new infections. So hepatitis C, who should we treat? Nowadays, it's less about who should we treat. We used to just be very careful about patient selection, and now it's more about, well, we should probably treat most people, so who should we not treat? People with a short life expectancy or palliative goals of care, they may not be having any symptoms whatsoever from their hepatitis C, so this might not really be worth their time and energy to go through this process. Patients that are acutely decompensated. So yes, we want to try to prevent patients from getting to the point where their liver is so sick that they become acutely decompensated, but they really kind of need to be in a stable place to be able to get the best chance of cure from this medicine. And so while, if I get consults in the hospital for people that are admitted for like liver failure, and they're like, oh, hey, should you treat their hepatitis C? I was like, sure, but not right now. But I do meet them and make sure that they know how to find me in the outpatient setting. The other thing is if it's not the right time in this person's life. So you remember from the chart that the hepatitis C does not hurt the liver overnight. This is a process that can take years. So if a person, I ask people like, are you planning to leave town in the next few months? Are you planning to change jobs? Do you have transportation? Or how important is this to you right now? And if it's not one of the things that they feel like is most important to them and they want to focus on right now, or they have to go out of town for work and aren't going to be able to make it back into town for their refills, that's okay. These treatments will be here in the future, I hope. And and it is okay if you want to wait until a little bit later to get treated. I think Clinicians that are older may remember a time where active substance abuse and mental health conditions were contraindications to treatment, but that is not the case anymore. Um, in terms of the active substance use, for my patients that are still using whatever their drug of choice is, I mainly ask them, do you think your use of this substance will prevent you from remembering to take your medicines? And if they say, yeah, when I go on a binge, I'm including alcohol. When I go on a binge, I just stop taking all of my medicines. Well, that's not going to work because the one thing that you really need to do to get cured is remember to take those pills every single day. And so we kind of talk through those things, and people are like, well, I think I could cut back drinking, remember to take my pills if it's just for the 2 months that I'm on treatment. And so we kind of do a negotiation like that. Same thing with mental health problems. It's more of like is your mental health problem going to affect your ability to take these medications? But those two things are not contraindications to treatment. All right, so now is the exciting part where you're in clinic with a patient. You've told them all about hepatitis C and what it is, and they're excited about getting treated, and you want to do their initial workup. I'm not going to read through the thing, but the initial workup are things that you would kind of expect. The initial workup is looking for other causes of liver disease, fatty liver being a prominent one, which is why things like TSH, A1C, and lipids are checked. The hepatitis A and hepatitis B tests are less so that I think they have those infections right now, especially hepatitis B is also very low prevalence in our patient population. It's more I'm looking for if they're immune or not, because then I vaccinate them if they are not immune to hepatitis A or B. HIV test is very important because there's a lot of co-infection of HIV and hepatitis C. And it used to be that patients living with HIV, there were different guidelines and I guess different treatment courses for them, given their potentially immunocompromised state. However, nowadays with the newer medicines, the treatments are pretty similar for people living with HIV and people without HIV. I usually do some sort of imaging looking for whether or not the patient has cirrhosis. So you can do an ultrasound or a CT scan. I usually like it to have been recent within the past year. They'll, I would say you get 3 answers on those about your liver echo textures. They'll say, oh, it's totally fine, or I guess 4. Oh, it's totally fine. Oh, there's some inflammation consistent with steatohepatitis, or they'll say cannot rule out cirrhosis, or they'll say cirrhosis. All of those are pretty clear. What we're trying to figure out is yes cirrhosis or no cirrhosis. So except for the one where they're saying cannot rule out cirrhosis, that's the only tricky category you might get there. The reasons it's important to establish whether or not somebody has cirrhosis or not is because the treatment course is different for them, and different lengths of treatment and different medications could be recommended. I mentioned before, you need to know the viral load and genotype. Patients might have had like a viral load and genotype done a year or 2 ago, and they finally make it to me in clinic, and they're like, hey, I'd like to get treated. And I usually say, hey, we should check your hepatitis C test again. Because while it's low and only 5 to 15% of people will clear the hepatitis C on their own, it is possible that they've cleared it on their own. And I've also had people who cleared a different type and then came back to me with another genotype. So it is, and you can interpret recent however you want. 3 to 6 months I generally think is fine, and it somewhat depends on the patient's risk factors. Again, one of the things you're doing for your new patient is immunizing them and protecting their liver from other things that are trying to hurt it. And if you do discover that a person has cirrhosis, then they are recommended to get the hepatocellular screening. And my recommendation is for a liver ultrasound once every 6 months. So how do we decide if a person has cirrhosis or not? Well, the ultrasound can be pretty clear, and the CT can be pretty clear, except there's that one case, which the radiologists like to use a lot, where they're like, advanced fibrosis cannot rule out cirrhosis. Well, what do you do with that? Do they have cirrhosis or not? Which way do I treat them? And so there are a bunch of different ways that don't involve a liver biopsy. A liver biopsy is pretty much never done to determine if a person has cirrhosis really ever anymore, but also for the especially for the purposes of hepatitis C treatment. Um, the things I mostly use to help when I get a wishy-washy ultrasound or CT read are the top two things, the FIB-4 score and the APRI score. These are tested calculations. There are calculators online on MDCalc on the University of Washington website that use the basic lab values that you are already getting. So things like platelets, your AST, ALT. One of them incorporates age as well. And they crunch some numbers, and then give you their thoughts about whether or not the patient meets the threshold for, over this 3.25 number based on the FIB-4 score. This person is really likely to have cirrhosis. So if I got a wishy-washy ultrasound read and they have a high FIB-4 or a high APRI score, I treat them as if they have cirrhosis. The trouble with the FIB-4 and the APRI scores are that other things that affect your liver enzymes can lead to falsely high values or inappropriately high values. So for instance, I was caring for a young man who was regularly using methamphetamines. His liver enzymes were always off the charts. His ultrasound showed no cirrhosis. And the reality is like, well, do I wait and see if he can get sober long enough for me to be able to check his labs to see if his liver calms down, or do I treat him as not having cirrhosis? And in that case, I felt pretty confident that his synthetic function of his liver was pretty good. And so I did treat him as not having cirrhosis. But do keep in mind, if a person is actively drinking or actively using some sort of drug that might hurt their liver, you're going to get falsely elevated values for your APRI and FIB-4 scores. There's also the FibroSure or the Fibro test. This basically does the same thing as the APRI or the FIB-4, but it's basically like a brand name. And so I don't really like that one. I particularly don't like it because in the past, insurance companies have used that as a barrier for getting people treatment. They've already come in and gotten like 8 tubes of blood drawn, and then you say, okay, I'm going to order your treatment. Their insurance company comes back and says, oh, you haven't done a FibroSure test. And then they're like, what? You mean I have to go get another blood test done that's going to show the same thing as the other one before I'm allowed to get my treatment? And so that's really frustrating. But I have noticed a lot of the insurance companies getting away from that these days. I would like to point out that the sensitivity and specificity of an ultrasound and CT or MRI are actually similar, if not worse, than the FIB-4 score and the APRI score. So that's interesting to consider that in some ways your FIB-4 and APRI score might be more accurate than your imaging. Transient elastography, which is the FibroScan, being the brand name, that I have listed the sensitivity and specificity there. It's not much more sensitive or specific than an ultrasound, a CT, and an MRI. That is another way to determine if you have transient elastography or FibroScan in your region, whether or not you want to treat somebody as cirrhotic or not. However, I tend to not get that because it's one extra step. It's expensive. It's not available in my region, and I can do just as well, if not better, with my FIB-4 and my APRI score. I think lots of specialists would say opposite. They all love the FibroScans. Hepatitis C medications. Here's where I get to talk to patients. Now that I have all their information, I get to help decide which medicine is going to work best for them. The medicines are safe. They are effective. They have minimal side effects. They're easy to take. It's like one pill once a day. And there are very few contraindications. I always do check those drug-drug interactions, though. Really, one of the, I don't know why I put this slide here, but one of the exciting things is that that's happened in the past few years is that patients can receive a hepatitis C infected liver or kidney transplant these days. Hepatitis C treatment, I think it's here because I wanted to show that like it's just treatments are so effective that they now will totally transplant organs with the hepatitis C infection because they know they're easily going to be able to treat it. All right, so the most commonly used treatments now have all these really long names. I really prefer to use generic names, but it is really hard to say lidipisphere sofosbuvir like more than once or twice. Same thing with velpatasvir sofosbuvir or glecaprevir pibrentasvir. So the first one on top there, you've probably seen commercials on TV for it. The lidipisphere sofosbuvir is Harvoni. It is, you can use that for genotypes 1 or 4. The bottom one there is Mavret, the glecaprevir pibrentasvir. That is pan-genotypic. You can use it through any genotype 1 through 4. It's an 8 to 12-week course. It is 3 pills, but those 3 pills are taken at the same time each day. The third medicine is the velpatasvir sofosbuvir, which is Epclusa. Again, that's pan-genotypic, and it's generally a 12-week course. It's 1 pill. Both the Harvoni and the Epclusa are 1 pill once a day, and they are renally cleared. And then the Mavret down there is hepatically metabolized. So you can't give it to somebody if they have Child's Q class B or further cirrhosis. This used to be really important because I would generally have to check and make sure, all right, does this person's liver work better? Does this person's kidneys work better? Or do both work fine? And I could use either medicine. But actually, one of the more exciting things in the past 5 years is they've done additional studies and shown that the Epclusa and the Harvoni, which are renally cleared, are still safe to use in people with renal dysfunction and even dialysis. So that sometimes it makes my choices a lot easier. For instance, it was a really big deal one time when I had somebody's who had both pretty significant liver failure and renal failure, and I had to decide which organ worked better. And I think in his case, I decided his liver actually worked better. When I'm counseling patients, I let them, oh, you know what? I haven't stopped for questions in a while. Should I do that?
Yeah, does anyone have any questions? You can either type them in the chat or
I haven't seen anything come up in the chat. Maybe that's why I forgot to stop. Okay, I'm going to keep going, but feel free to type questions into the chat. I'm not looking at like the faces on the screen, so if you raise your hand, I'm not going to see it. So, but Mario can interrupt me if I need to be interrupted for a question. So when I'm counseling patients, I let them know that the medications have minimal side effects. I've heard patients say they have headache, nausea, insomnia, or sleepiness, dizziness, pretty much the same thing that any medication on the planet can cause. For most patients, the side effects are mild and they resolve within 1 to 2 weeks as your body gets used to the medicine. With the old hepatitis C medicines back in the days, there was a risk for hepatic decompensation with those medications. That is not the case for the new medications. These medicines are safe and they don't have any significant long-term side effects or really any dangerous short-term side effects either. All right, so which medication do you choose? You think about genotype, previous treatment, and whether or not the patient has cirrhosis. You think about renal function and hepatic function, and I already made the comment about how we now know that those 2 medications work even in people with renal failure. I look at medication interactions. So the people, like one of the things that happens most often is that the people who are on PPIs, but I want to give them that medicine, I first try to get them off their PPI, and then if I can't, then I consider the other course. And then we also think about HIV co-infection. So do I memorize exactly which medication to give to whom? No, actually, because every time I seem to look at the guidelines, it changes, which is awesome. The hepatitis C guidelines are listed at the top there, www.hcvguidelines.org. It is a shared enterprise between, well, not an enterprise, but it's a shared project between the AASLD, which is the Liver Society, and the IDSA. And I do think that the CDC might be involved with it as well. But basically, they continuously review the guidelines and continuously update it as new information is obtained. So it's, in my mind, way more awesome than the cardiology guidelines that come out. And by the time they've come out, they have new evidence and they have to redo their cardiology guidelines. So I like this one because it's continuously updated. And it's just been so exciting to see, even in my career, I've been here at Shiprock for 8 years, that the treatments have gotten easier, more available, and the medicines are safer and better than they used to be. When I have a tricky case, I do have some different resources that are available to me. I do work with UNM Project Echo. There's a Hepatitis C Echo. There's also a UCF clinical consult line, and I have worked with them as well. They're different. The two, Project Echo and UCSF, are different formats for getting advice in different timelines. So I kind of use whichever timeline is easiest for me at that time. But they're both like remote consultation services, essentially. All right, so when I initially started giving this presentation back in 2019, I went to the stateofhepc.org. And basically what stateofhepc.org does is it looks at the Medicaid requirements for allowing their Medicaid to pay for hepatitis C treatment. And what this graph shows is in the light colors, so white or pink, those are the states that in 2019 had the least restrictive Medicaid requirements for getting hepatitis C medications for patients. And I'll go over what those requirements are in the future slide. The red or dark red, or I guess dark maroon in this case, are the states that had the most restrictive requirements. I was happy back then to live, and I like that they made it a report card and they gave like an A, B, C, D, F grade. Even though I know, I think a lot of our schools are going away from that kind of thing, but I was happy to live in a state that got us at least a B. I was really excited when I made the presentation today to find out that while they've chosen different colors, the map does look a lot better than it used to. So now they've been able to add A plus, and luckily I live in an A plus state, and in the Four Corners area here, I'm next to Colorado, which is in a green state. Utah needs to catch up; they've got a C, and then Arizona, it actually gets an A now, where it used to be in the red zone. And there, I don't see any more red on this map, which is great. So I was really excited to see the improvement from before to now. So what kind of requirements is this stateofhepc.org looking at? And yeah, this is the page that lists that. So insurance imposes barriers nationally. So some states would say, or some insurance programs would say, you must be a specialist to prescribe the medication. So there are a couple different ways to get around that. So I'm a family doctor. I don't think I would be considered a hepatitis C specialist. They want a hematologist or an infectious disease doctor. However, I got around that restriction because I do have an HIV medicine certification. So whenever they would complain about that, I would generally send in that certification and they would say, fine, we'll give you the medicine. But for those of us who don't have HIV medicine certifications, using even the remote consult sources like that UCSF clinical consult line or the Project Echo, those do count as a specialist consultation, and insurances would accept the recommendations from those programs as the specialist recommendation. So if that's available to you, then that is a really good way to get around that one. But I think a lot of states are moving away from that requirement. There used to be sobriety requirements. They required people to be sober for 3 to 6 months to a year. Like, it just was completely random, not based on any data. And it was just a really discriminatory practice. Again, I don't have a sobriety requirement. I just ask patients, is this the right time in your life that you're going to be able to remember to take your medicine so that you can have the best chance of cure? Other states would not necessarily have a sobriety requirement, but would be requiring them to participate in a substance abuse treatment program that probably had a sobriety requirement. And that, to me, is extremely discriminatory and extremely difficult to implement, as we probably all know and have experienced how difficult access to substance abuse treatment programs is. I think the most infuriating one for a lot of people was the insurances that would require people to have advanced fibrosis in order to receive treatment. So my whole logic is that if we treat people before their livers have cirrhosis or advanced fibrosis, then we are keeping their livers healthy and saving them from all the morbidity and mortality that goes along with having advanced liver disease. So my idea would be to treat them as early as possible. This was really just a way for the insurance companies to limit the number of people who had access to treatment. And while there are some people whose livers are able to regenerate and they are able to work better than they used to and have a remission of cirrhosis, that's not everybody. And a lot of people still continue to have pretty significant symptoms from their liver disease, even after you treat their hepatitis C if their liver was too far gone at that point. Again, I think I mentioned before that some insurances would require these special tests, and that was very frustrating, especially living in an area where access to those tests wasn't necessarily easy, and also it's like an unnecessary expense, an extra step. All right, so whether or not you have started your patient on hepatitis C medicine, or you have sent the patient to a specialist and a specialist has started your patient on hepatitis C medicine, they come to see you, whether it's an urgent care or for a primary care visit. And what do I want you to know? All right, well, Dr. Allen, I'm not going to treat hepatitis C, but what do I need to know if I'm seeing patients that are on treatment? Well, they're only going to be on the treatment for 2 to 3 months. So think about what you're doing and whether or not what you're doing can wait. So avoid disruptions in treatment. So when I have patients with cirrhosis, I don't and you know, the recommendation for patients with cirrhosis is that they get an EGD to screen for varices. Unless they have actively bleeding varices or concern for that, I don't make them wait to get their EGD before I start them on their hepatitis C treatment. But at the same time, I try to avoid them having procedures or surgeries, if possible, while they're on treatment, because they always want people to hold their meds and things like that. Ultimately, will missing a day or taking their medicine late one day make a difference? No, but complications can happen. Things get wonky. If they end up admitted and the facility they're admitted at doesn't know that they were on the hepatitis C treatment and does not continue it for them, that can lead to trouble. So I try to figure out what's going on in people's lives, try not to sign them up for elective procedures when they don't need it while they're on treatment. Medication interactions. I always look for medication interactions. All of these things decrease the absorption or lower the efficacy of the hepatitis C medicines. So I just use standard medication interaction checkers, or you can ask your friendly pharmacist to do that for you. Again, side effects when I'm counseling patients are usually mild. And they're like, well, which one? Oh, and then so, you know, usually I'm offering somebody like, okay, do you want to take the Epclusa or the Harvoni? The Epclusa or the Mavrette? And they're like, which one is better, doctor? And I'm like, well, they both have like a 99% cure rate and they both have minimal side effects. So it's kind of up to you. With the Mavrette, it's 3 pills once a day. Many people can get by with taking it for only 2 months. And so it's a shorter treatment course. And so some people are like, all right, I think I can cut down on drinking for 2 months so that I can get through this treatment. And so they want the shorter course. But other people are like, no, I only want to take 1 pill. I don't want to take 3 pills each day. And so for them, the 3-month treatment with the 1 pill once a day medication might work better. So I try to let patients choose as long as the insurance doesn't come back and say, no, we're going to choose something else for them. Once I've started somebody on hepatitis C treatment, I like to check in with them to see how they're going. My team and I try to call them 1 week after they've started the medicine, mainly to ask about compliance and tolerance. How are you doing remembering? Are you having any side effects? It used to be recommended that everybody get labs at 4 weeks. You're checking for checking like CBC, CMP, viral load. That was to check to see if the medicines were having, and this is the language I use with the patients, any internal side effects on their liver, kidneys, or blood counts. But over time, they've seen that, well, there really aren't internal side effects, so we don't really need to keep doing those 4-week labs for that. Another 4-week lab that was considered was a viral load. And nowadays, we don't always do that, but we can do it as a marker of adherence. So for instance, if we're worried about a person not taking their medicine as frequently, or if they've told us I'm missing a ton of doses or I missed this amount of time, you can do a viral load at 4 weeks to check on like how adherent have they been. Because if they've been taking the medicine, it should be an undetectable viral load already at 4 weeks. The other thing you do is check a viral load at the end of therapy. That's also somewhat of a marker of adherence, and just to make sure things are going in the right direction. At this point, I think that's probably also an optional one as well. But I do tend to do it. People do like to see these labs because it's like a tangible thing for them that, hey, we're making progress here. This is probably going to work. Um, let's see. And then the really exciting one is you check a viral load 12 weeks after finishing the treatment. And that is where you get to see if people are cured or not. So, um, is my patient cured? This is kind of just a review from what the lab looks like at our facility. You want that hepatitis C quantitation to come back as undetectable or less than whatever your lower limit is. And that it's called, in the studies, it's called SVR12, sustained virologic response at 12 weeks. And nowadays with the medicines we have, it's been shown that if you are undetectable at 12 weeks, then you are cured. Okay, great. You have a patient, they got treated for hepatitis C, they're cured. What do you do with them now? There's not necessarily a recommendation to recheck viral loads in the future because we know the medicines worked at that point. However, if the patient has ongoing risk factors, then yes, it is still good to continue to do hepatitis C screens. However, you can't necessarily just use the antibody to screen them. The antibody is always going to remain positive in a person who has had hepatitis C before. And the antibody positivity is not protective. So a person who has had hepatitis C and either cleared it on their own or been treated for it can get reinfected just as easily as if they had never had it before. And then there was I think a number of people have asked, who do I do the hepatocellular carcinoma screening in? Do I have to do it in all people with hepatitis C? No, only in people with advanced fibrosis or cirrhosis. And, and the Liver Society will tell you that the recommendations for hepatocellular carcinoma screening in people with advanced fibrosis or cirrhosis are to do an ultrasound plus or minus an AFP every 6 months. And my recommendation is just to stick with the ultrasound. I just don't like the AFP test. I used to have a whole slide about it, but I ended up ranting too much. It just has a terrible sensitivity and specificity, and it doesn't really give you much extra information. Furthermore, I never check it in people with hepatitis C because hepatitis C falsely elevates the AFP and then just creates a whole series of worries of things. So it's not really a relevant test in patients with hepatitis C. You do expect that AFP and elevation to go down once you've cured their hepatitis C, so then you can do what your standard practice is as to whether or not you want to use that test or not. Okay, so here we are back at the learning points. I hope we've all gotten to understand that the hepatitis C medicines are safe, easy, easy to take, minimal side effects, and very effective. There are very few contraindications to treatment. There are medication interactions. Just because a person has a positive antibody does not mean that they are infected for hepatitis C, so don't freak your patients out. And then treating hepatitis C early saves lives. All right. And then I think for a long time now, there's been a discussion about whether hepatitis C was a job for primary care. And so if you don't have any questions, that's my question for you is after this talk, I hope you might feel a little bit more confident about at least maybe even doing the first few steps of moving toward a patient toward treatment. But what questions do you have for me, or what are your thoughts about my question?
I have a question. Um, when I'm seeing a patient that has hepatitis C, he's cured, so viral quantity was negative. And then I see him back after 2 years. And there's now a mild elevation of LFTs. I don't feel too concerned about he having a localization of hepatitis C because it's like just a mild elevation of LFTs. I mean, like very mild. It's not a thousand. Like I'm assuming I would expect if someone has regularization. Is that correct?
There was a lot of interference, so I'm going to repeat the question and you can tell me if I got it right. I think your question was, A patient had hepatitis C before, and then he came back a few years later, and his liver enzymes weren't really very elevated, maybe mild elevation that we see in so many people these days with like fatty liver disease. Should I be worried about this patient still having hepatitis C? And the answer is that the question?
Yes.
Okay, great. And so the answer is absolutely, you should be worried about this patient having hepatitis C. With hepatitis C, you rarely will see the elevations into the thousands. You do see that with other disease processes. I've actually never seen anybody with liver enzymes above like the 200s from their hepatitis C. So you see the same kind of mild liver elevations that you see in people with fatty liver disease. You can even have completely normal liver enzymes and still have a hepatitis C infection. It just kind of depends on how well your body is trying to fight it off. So just looking at the liver enzymes isn't necessarily a good screening test, and it's definitely worth repeating their hepatitis C test to see if they still have it. I think the only times I've seen liver enzymes above 200 or 300 in a patient living with hepatitis C is when they were concurrently using drugs that might hurt their liver. And so you can see really mild liver tests on that situation. So thanks. That's a great question.
You mentioned something earlier about fighting with insurance, trying to get a specialist to do it instead. Is there any kind of hepatitis C training or CERT or CE that we can do in place of that to help with that?
Yeah. So right, I think they're getting better about having those restrictions, and certainly in New Mexico, we now get an A+, so you're not really going to come across that. But if you're wanting to get more confident in your ability to treat hepatitis C, I would actually recommend, and I recommend this to the students and residents that rotate with us, recreationally reading through the hepatitis C guidelines that I pointed out. Medical stuff doesn't make for great recreational reading. And reading the how to treat and which medicine to pick is not really a relevant section to try to memorize or things like that. I tend to recommend reading some of the sections about special populations, how do we evaluate for it? And then every time I see a new patient, I get their genotype, I get all their information, and I recheck the guidelines to make sure it hasn't changed since the last time I looked at it, to make sure I am recommending the most efficacious and safe medicine for them. And then in terms of so how did I end up doing this? I was particularly interested in residency in patients living with HIV. So I did some extra training on that. And because co-infection with HIV and hepatitis C is fairly common, I ended up doing a fair bit of hepatitis C treatment through that process. And so I had more just experiential learning. And are there formal programs out there for hepatitis C treatment? There are lots of different conferences that you could choose to go to. And the University of Washington, I know, has a really good HIV.
It's actually really very thorough.
Yeah,
Just the first section is 8 hours. It's like 50 hours or more of reading and time. I did the first 8 hours.
Yeah,
it's actually very good. Yeah.
For HIV at the University of Washington.
Hepatitis C.
Oh, okay. And so great. So the University of Washington does now have a hepatitis C one as well. So that's actually the one, if you wanted kind of more of a teaching thing, that is a really, really great resource if it's anything like their HIV one. So awesome question. Did I answer the question?
Yes.
Okay, good.
Really start treating non-complicated patients.
Yeah. One of the more fun things I'm doing, and actually the thing I'm most excited about my job right now, is I'm teaming up with our street medicine team. Our street medicine team has some family docs on it, but the woman who's running their hepatitis C treatment initiative is actually an emergency medicine doctor. So she is self-taught. She learned how to do treatment of uncomplicated hepatitis C, I think at one of her street medicine conferences. And she came to me and was like, hey, can I do this? And I was like, absolutely, no problem. That sounds awesome. And so we even have a way whereby she just can automatically treat the uncomplicated patients. But if a patient has some sort of complicating factors, or even if they just have cirrhosis, she consults me. However, I don't require that the patient see me. I just kind of talk through the case, see what tests we want to get done, walk her through the steps, and she can oftentimes get everything done with the patient out in the field with me not ever actually seeing them. So that's one of the more exciting things going on with hepatitis C at my institution right now. And it's because that's a large portion of the population here that hasn't been treated is patients that I can't access because they can't make it into the clinic for visits.
It really is pretty easy to do the uncomplicated patients, as long as they're compliant about coming back.
Yep.
I had one that had mental health problems, is out polysubstance abuse on the streets, in and out of mental health organ. He's never followed up in about a year and a half. So don't know if he ever took the meds, but it's, you know, it's pretty simple. Yeah. So I recommend for people to read and decide if you want to. Might do some of it. Jen Prosser does some. I know at La Familia, you do some over there too. You have a pharmacist there too that helps out.
And Maria
Yeah, Maria.
for healthcare.
Yeah. So it's actually pretty straightforward, easy to do, because you have really no GI access here in town.
Yeah, and having a pharmacist to help you out is pretty awesome, especially because a lot of the insurances are going to make you fill out forms, and your pharmacist can kind of like help you navigate that system. I think one of the things that used to be really helpful for our patients that didn't have insurance was the patient's assistance programs, but for whatever reasons, those are not nearly through the drug companies, but for whatever reason, those are not nearly as easy to access as they used to be, but still probably exist to some extent. And I let my pharmacists help me out and guide me in terms of what, if we can't get it through their insurance, what are some other options?
All right, if we have no other questions, Dr. Allen, are there any final thoughts you want to share with everyone?
No, I think you got a lot of my thoughts today. Thank you so much for listening.
Thank you.
Thank you. Great discussion.
All right, with that said, everyone, have a great rest of your day and thank you for attending.